I was trying to think of what to say and how to start it, and I was having dinner with my kids in the local Chinese restaurant. I'd opened the fortune cookie, and there was the answer. To every complex problem, there is an easy answer, and it's usually wrong. And I'd also like to thank Pamela Suvlas, a friend of mine, who's a creative director, and qualitative innovative researcher at Pollinate, who's helped me a little bit with concepts on innovation. So I went, like a modern old man, to Wikipedia and I looked up what is innovation. Innovation's a new idea that is actually more effective. A new idea is not necessarily good. It may be new and it may be bright, but it's actually not necessarily good. And I'm going to go through a lot of my concepts or my results as some of them are new ideas that aren't actually innovations. And if we want to make change, we've got to create or invent. Then we've got to prove it's actually good by being an innovation. And then we've got to diffuse the innovation. And many years ago, Ludwig van Mises said an innovation is a whim of the elite before it comes to the need of the public. And it's very relevant to public hospital medicine. And it shouldn't be a whim of the elite. It should be actually for the public and better for the public. I'm focusing mainly on surgery, and everyone knows Richard Horton, the editor of The Lancet, his great quote of surgical research or comic opera, questions but few answers, which is the title of his article. His article was actually a lot more supportive of surgical research than the title, but that's probably one of the most commonly quoted assessments of surgical outcomes research. But even Spodek and Jammer in the 1970s described the surgical literature of 1,000 zeros still equating to zero. I was honoured to get the Foundation Medal for Research and Innovation, but when I looked back over the last 15 years, it was very there were no surgeons, and in fact in a hospital that is innovative and into research, surgery was very poorly represented. The key words I want you to remember, after David's brought it up, is equipoise. I coined that in surgery in 1994, and we've been using it ever since. I quite like it. That was the word I went to the area health board chief and said equipoise, and she said, what does this mean? I really like this word, and I think she funded us purely on that word. I think that's probably a bit cruel. I'm going to talk about influences, facilitation of innovation, co-creation, documentation, and then narcissism, just a little bit of a touch of which I have. Henry Ford said if I had asked people what they wanted, they would have wanted faster horses. And that's true. Sometimes when you ask people, you don't actually get what you really should be doing. But he was an influencer, certainly an influencer on the car industry into innovation from there. So how do influencers help innovation? They think big, they're creative, and they're very persuasive. And they stretch the boundaries, and they're not afraid to stretch and to tread on toes. By their nature, influencers allow surgeons to look ahead and to not gaze into their navel, but actually gaze to the horizon. And not to seek the comfort of the familiar. And that is one of the big problems in surgery. You get trained, you have to learn the technique, you get comfortable in your technique, and then once you're comfortable in that, it's very difficult to say that what you're doing is actually wrong. Einstein said the definition of insanity is doing the same thing over and over again and expecting a different result. Co-creation is a concept which is very important in surgery and very important in medicine, is that we don't create innovations or new ideas on your own. And in fact, I think the best innovators are the ones that talk to other groups, go cross groups, talk to other surgeons in different specialties. So I think co-creation leads to breakthrough in ideas. The white canvas for innovation process must follow clearly defined divergent thinking, which is expansive and creating, and then convergent thinking, which is focus and discipline. And for us in clinical medicine, someone's got to come and create this divergent new idea, but then you need outcomes units and things like that to actually prove that it's actually not just a new idea, that it's an innovation. Thomas Edison said, to have a great idea, you need to have a lot of them. And what that really means, you've got to expect failures. And don't be put off by the fact you fail. I'm going to talk very quickly about the diffusion of innovation, but it's very interesting. It's been right back in the business sector in the early 1900s by Gabriel Tard. First, you need knowledge, you need then to form the attitude, and you need to then decide to adopt or reject, then you implement, and then you confirm the decision. It sounds great, but he was the one to first describe this S-shaped curve. And what is more interesting here, if you look on the left-hand side, and this is what's really relevant in surgery, only 2.5% of people are actually innovators. But right down the other end, the people who are really anti-innovators are the laggards, and there's actually a lot more of them, 16%. And that's in business, but I'll show you what our data is in surgery. So a requirement of innovation is to recognise the method, competent people to utilise the method, and extremely important is financial support. This is our data from multiple studies on equipoise and patient preference assessing surgeons. Surgeons' attitude to new innovation and new ideas, 30% are enthusiasts. We always think we think the same in surgery, but in fact we're very different. 30% are enthusiasts creating new ideas, liking new ideas. It's balanced pretty equally by 30% who hate change a priori. The group 2 think group 1 are zealots and should be thrown out. And 40% weigh up the pros and cons. So it's a little bit different to business where it's 2.5 versus 16%. So where do we get sources of innovation and new ideas in surgery? And I'm sure it's in medicine. Journals, I think, journals confirm what we're currently doing is probably okay. It's not a great source to me of inspiring innovation and thought. Conferences, if you go to a conference and you leave with one good idea, it was a great conference. It's usually to have trial meetings. It's usually, again, to confirm what you're doing. You haven't missed something. What's much more important as a young surgeon is your mentors, and then as you get into practice, your peers. Advanced trainees and fellows, to me, is an enormous source, particularly international ones that come in with new concepts, and research staff. As David suggested, we started Source actually in 2012, and it's a collaboration of 4 directors, myself as a surgeon, a clinical epidemiologist, a health economist, and a clinical research psychologist. So it's co-creation using completely different concepts to focus on surgery. But not only the directors, these are all the researchers who work with us, they all have actually quite good input and influence new ideas within the group. As David says, that co-creation and that out of your discipline has been quite successful when we celebrated our first 10 years. But not only that source, you also look for surgeons in different disciplines. They can look at your approach and say, well, we've done that in a different thing, but it's quite similar. You look at other physicians in other specialties, which we use all the time. Allied health and nursing is a particularly good source. Cross-university disciplines, those would have heard Mike Eason talk about arts and drawing within surgery. They're innovative creation to improve the standard of care. But by far the most important, and I'll show you my data on this, is actually the doctor-patient. It's actually your patients and your experience with an individual patient that I think leads to new ideas and hopefully innovations. But what is even more interesting, that every patient is understanding every patient is a different personality, and in decisional conflict, which is where we're at a really important crossroads to decide whether surgery or not, there are different personalities that need different and give you different information, and they're vigilant, fast and frugal heuristic, the buck passer and the procrastinator, and what they want and what they give you back in information actually depends on you understanding that personality. We've been particularly interested in creating novel ways of assessing patients' preferences for surgery. And this is an example of one in Crohn's scenario. And what we looked at decisional conflicts currently within Crohn's, both medical and surgery, and we found that half the time the patients disagreed statistically with their gastroenterologists. They never disagreed with their colorectal surgeons. And in 2/3 of the cases, gastroenterologists differed with their surgeon. We thought, fantastic. We continued it on in ulcerative colitis and found completely the converse, that in fact patients and gastroenterologists were right for what patients want. We've developed these new ways of measuring prospectively patient preferences using retrospective quality of life type measures to measure this. And we've done it through a whole range of surgical conditions and even caesarean sections within obstetrics to actually measure what patients really want. And what we have found is patients are in the same direction, but they'll often trade a lot more than their clinicians will do, particularly when it's survival versus quality of life. So what do my research come from after 20 years of private practice and in academic surgery? So my 2 areas I'm going to focus on are minimally and maximally invasive surgeries. So it's one extreme to the other within colorectal surgery. And I'm often asked, and I was asked to give a talk to fellows once when I retired as a chairman of a training committee, and they asked me to say, how do you do academic surgery and have private practice? This is the constant problem within surgery. And I titled it Success Through Failure and a Touch of Narcissism, and I think it's probably true. So often young surgeons say, why did you get interested in research? Often patients, friends, non-medical people say, what do you actually research? Have you discovered anything? I find that extremely difficult. I often have this pregnant pause and then say, oh, I'm not sure, not really very much, I don't think. Very hard to say what you've done. So I went through my publications and I said, well, I went through it quite critically and said, what were actually a new idea. Now, not an innovation, I'm not saying it's actually good for a patient yet. What were actually new ideas? And started listing what were actually new things in the literature that had never been in the literature. And then I actually went through those same papers and said, where did that concept come from? And if you go down that right column, you can see patient. Early on in my career, patient and mentors were undoubtedly the biggest influence on new ideas and leading to publications. Occasional self, a registrar, trial design, we had to develop things for a trial design, cross-discipline, but you can still see patient and cross-discipline. And in my later interest, which is pelvic exenteration, with innovations that we've published, again, you can see cross-discipline, patient. It's mainly patient and cross-discipline that is actually inspiring the co-creation of innovation of ideas, if I look back retrospectively into my area. This is an algorithm I did in my master's in Toronto, and equipoise we coined then. And equipoise is the state of uncertainty in clinical decision making. And it's actually equipoise that should be the measure that drives innovation. So we need to measure when there's equipoise, and that should be the stimulus for innovation. And just to show you, this is back in the early 80s, I did this study with the late Jeff White and the Vascular Association of Australia and New Zealand. And we were looking at what was equipoise in endoluminal aneurysms and stenting and carotids. Now, this was very early on in the piece, and now you can see in that graph there is equipoise. There's actually 65 are favouring open repair for the average risk, but you can see here there's not equipoise. You would not get these people into a randomised trial for high-risk patients. In fact, endoluminal would not actually, would be much more favoured in the high-risk patients. And the converse was present in carotid endarterectomy. So we can measure the uncertainty and therefore the need for trials and the actual accrual into trials. And you can see in this one, that's a perfect equipoise graph. On 0, where you're completely uncertain, is by far the most common measure. So what about failure? I found this in the sports, where I get most of my inspiration, in the sports page. Why success often means failure. And I think you have to be prepared if you want to innovate into it. In surgery, certainly, then you have to be prepared for failure. I heard we were talking about humility this morning. I think narcissism, a tight touch of narcissism. I look at innovators and I meet them, and I think there's a little bit of touch of narcissism. I think I certainly have it. I think grief. I go through grief a lot when I'm doing publications, trying to create ideas, getting criticism back. I think narcissism and grief are definite personality traits or experiences you have to get used to. I think humility is an optional extra, unfortunately, in innovation. But are innovators outliers? Malcolm Gladwell, I find half of his books very interesting, then the other half gets a bit boring. But he's got some great ideas. He's actually a Canadian who writes for the New Yorker. But his success in innovation, he has 5 things. You need to have given the opportunity, which is important for mentors. You have to have some talent. You've got to do the hard yards. Erickson's classical educational 10,000 hours before you can actually get prepared to innovate. And then you've got to have opportunity. So you've got to get knocked down with adversity and then pick up on your opportunity, and then there's luck. This is the 2015 Bloomberg Innovation Index, and you can see Australia's not on it, but you can see some small countries there: Singapore, Finland, Israel. We've got to work on that. I mean, we're actually we should be up there in the top 10 of innovation. And if you look at in medicine, we've got 6 out of the top 50 medical schools are in the top 50 around the world for a population, which is much better than Canada, which is quite academic. I know we're on the way down, but we won't get into that at the moment. But if you look in surgery, though, we're not up at that level at all, and we need to actually innovate more. So where are the sources? Mentors. Mentors are extremely important, particularly in surgery, because a lot of it's an apprenticeship and a lot you learn. Again, I went back to the sports section. What do you look for in a mentor? You can't find this anywhere, but I found it in the sports. Pam Schreiber. And if you look, Mark Zuckerberg, Steve Jobs, great innovators, great understudies. My first publication probably meant the most in understanding how a young person can use a mentor to help you. I was up in New Guinea on one of the rotations from Prince Alfred. I had a young kid with idiopathic portal vein thrombosis, which occurs in The islands, predominantly, no one knows why, it's idiopathic, but they have got a normal liver, they have giant varices, there was no gastroscopy, this in the early 1990s, no tips, and the treatment in New Guinea is to let them die. They come in vomiting blood, they come back again, and eventually they die. Everyone accepts it. I rang my mentor in Sydney, Michael Stephen. I said, this is just wrong. What should we do? He said, shunt it, operate it. I rang him because I knew he'd say that. If I rang with someone else, he would have said, let him die. He told me how to do the shunt. I'd worked with him for 6 months. He said, you must do it. You can't just say you can't do it. I asked the senior surgeon. He said, fine. He got on the publication. He helped me during the operation, got chest pain during the operation. I had to pull in the orthopaedic registrar, which is the second author, to finish the operation. And he survived, and on day 4 he had hematuria, and I disconnected the renal vein from the kidney, and on day 3 he had hematuria. It fascinated me or it worried me for days and months what happened to that kidney that I disconnected. He stopped bleeding. I know he was alive 5 years later when the fellows were still going up to see him, or the registrars, but I was fascinated. I then went to my next rotation, which was Darwin. I met a great mentor who was John Hargrave. He actually had a microvascular lab. I finished up, he pushed me to do a Masters of Surgery. I failed. And I'll explain my excuse as to why I failed. We had a great literature review of portosystemic shunting. We had developed a novel model of extrahepatic portal hypertension in a white rabbit, and then we found the critical point of cut-off where the kidney died. Pretty interesting stuff. I did it all in part-time on Wednesday afternoon and nights, and all day Sundays. I wasn't a very good husband. And John Hargrave was a great mentor. He ran that laboratory. If you look at his history, he was a GP, he worked in Northern Territory. As his MD thesis, which he did after the fact, he mapped active leprosy throughout the Aboriginal population throughout Northern Territory. He not only mapped it, he then eradicated it by treating it. Once he'd eradicated it, and he's still going around to these clinics, he noticed all of these cured people had weird hand deformities where you have paralysis of 2 fingers, 1 finger that works, the rest of the hand. And he taught himself hand surgery. He taught how to move that tendon to the thumb so they could oppose, so they could eat. And he was recognised so much so that the college made him an honorary fellow of the college, and he was a great inspirer for me. I said I really wanted to test this theory about the kidney. He said, use my lab, got it through ethics. He helped me get going, and then implored me to write it up as a master's. I then had the bad mentor. I had to then go back to the university, submit it to university, because I had to have a supervisor. The old professor said, yeah, I'll be your supervisor, great idea. I moved to Toronto. We had no internet, email. It went through and they said, look, there's a technical problem here. You're supposed to have done 2 years full-time. I actually didn't even tell them what I'd done. It says, we think you only did 1 year full-time. I left it at that. You'll have to come and talk to the postgraduate committee about getting an exemption. He then said he would go, didn't turn up twice to the appointment. Now that's the difference between a bad mentor and a good mentor, and I can't tell you in innovation and in research in young people the difference between the two. A good mentor has to provide the incentive, the pathway, the structure to the train to get your 10,000 hours in surgery, and then provide the job opportunity early in the training so that you don't have to waste your time worrying about where am I going to be in 1 or 2 years. You can actually concentrate on innovation and build that into your career. There are 3 great mentors from the 3 different continents in colorectal at our hospital at Prince Alfred in '78, Gallagher from Leeds, Hughes from Melbourne, and Turnbull from Cleveland. And these are great documenters. And an innovator in surgery can also just be an excellent documenter. And Mark Killingback in Sydney was a great documenter. And it's great for hypothesis generation, creating new ideas, but not for testing them. But good mentors are good documenters so that they stimulate you to then actually follow it up with your patient-doctor experience. It's good generation of new ideas, but you need to do good testing. What about collaboration and co-creation? I think certainly in surgery and source and that, we've definitely adopted the SWANS policy, and I think it's extremely important. There's nothing worse, particularly when you know there's a lot of narcissisms, particularly in surgery. You've really got to have that policy. And the underlying principle is you want to do good work research, you need an innovative atmosphere, and you must attract great colleagues. And great colleagues, you must let them go past you because they actually make you look a lot better. And I think that's what I've done, is attract good people who are actually making me constantly look a lot better than I am. I'm now going to do critical tearing apart of my 2 areas of innovation or new ideas, minimally invasive surgery and maximally invasive surgery, which picked up in the 90s when it all started, laparoscopic surgery, and then maximally invasive surgery. I'll say that that's my 7 levels of evidence, and down the bottom is when you start believing in yourself, you've got to be very careful. Okay. We did the first lap Crohn's, and these are historical control studies in the early 1990s, so we were very innovative in laparoscopic surgery in the 1990s at RPA, publishing a lot of historical controls. We've got the biggest World Series in lap ultra-low rectal endometriosis, and we actually did our first and last robotic-assisted one in Australia in 1997. We still don't have the robot since 1997, unfortunately. So where are we? Yes means in those conditions, and they've only got historical controls. We've done 4 randomised controlled trials assessing this, and what we have shown along the way in the evidence base is that the early studies were accentuating the benefits by 30% of non-randomised versus randomised, and Dave Urbach in Toronto has even looked at the randomised trials and shown, quite interestingly here, that the benefits we're seeing in poor research or lesser standards of research is actually negated by the better standards of research. So unfortunately, I think I've spent the last 20 years doing something that is a new idea. It's actually established, patients and doctors want it, it's new technology, but as a scientist trying to make an innovation, we've wasted our time. There's actually no benefit from it, except for the expectation that it may be better. So I think I've probably, in some ways it's a failure. When we published the historical controls, people didn't do it and it was benefit. We published the randomised trial showing no benefit, everyone started doing it. So what about pelvic exenteration? In the 1990s, it was uniformly fatal within 12 months. The goal is to get it out, be radical and get a clear margin. That's been proven in meta-analyses in our RPA data. So we know if we get a clear margin, we get good survival, but unfortunately 30% of people in some series would die within hospital without getting out of hospital from sepsis and bleeding. So that's when we started. Our ideas for innovation in our program came from peers, came from cross-discipline surgeons and physicians, and particularly the doctor-patient experience. This is our collaboration with peers around the world. We've now got the biggest collaboration of recurrent rectal cancers. Up until the 90s, the biggest of the series were about 30 to 40 patients. And our holy grail in 2000 to mid-2000 was to get a 49% rate of a clear margin, which would give you a 30% survival. In the posterior compartment, the sacrum, where everyone died from bleeding, they only had a 30% R0, and the Memorial had the best series in the world of the lateral, which was 19% terrible, not worth doing it. We've created minor modifications driven by patients. Each patient, we said, well, we could try this and get that out. So there have been technical innovations within surgery, which I'm not going to go through too many, but we've published a lot of bone approaches. We've now got our sacrectomy posterior compartment up from 30% up to 75% by these innovations. And they're high. We're only one of the few centres in the world that does high sacrectomies. And in the anterior compartment, which we've always thought was the easiest, we've actually adopted new ways of attacking the urethra and the bulb of the penis and taking the bone. This has never been published elsewhere. We're just publishing this now to get the pubic bone, and we've got our R0 up, which is the best compartment, from 63 now up to 94%. And our lateral compartment, when Memorial published, we were 21%, very similar compared to our centrals of 71. We developed a new radical approach to this area which no one else would go, because that's again where you bled to death. We understood the surgical anatomy, and we then created ways of removing bone to get to the sciatic nerve. We got our R0 in our first series of 39 patients from 21 to 53%, and we're just publishing now in the British Journal of Surgery 200 cases of this lateral compartment where our R0 is up to 68%. So I think this is an innovation by minor surgical modifications, and that's what we do largely within surgery. And what we've got is all of these are uniformly fatal conditions. We now have 5-year survival data down the right-hand column from 38%, 34%, up to 62 and 75% for what is uniformly fatal condition 10 years ago. And I think that's an innovation by patient-driven and peer. What about advanced trainees? These are publications we've done which have been helped by trainees. Either a concept was brought through by them or we work with them to get these publications. We are lucky we get 2 out of our 4 fellows funded from overseas to work with us, and they bring new ideas. They are a fantastic source of innovation and new ideas within surgery. And I'll finish with our Institute of Academic Surgery. Can we set up a structure to inspire the young surgeons to innovate? This is our new restructure, and if you go down the left-hand column, we have a whole department of innovation, thought, and values with an executive director from the university who's a health economist and a whole unit now to set that up. That's the building we would like. We've only got 2 stories, but we'll have to fit innovation in somewhere. But if anyone's got 60 million, then we'd love to have that. So in summary, the principles of surgical innovation is that every patient is a source of learning and as such a potential inspiration for innovation. Don't do the same thing over and over again. Don't just accept current dogma. Question how can you do it better. Remember, 30% of surgeons are going to block you and they're going to say, criticise you, so be prepared for that. Remember, new ideas are not necessarily innovations, and construct the evidence base to support the idea so that you can diffuse. And hopefully those 5 or 6 concepts I've touched. Thank you very much for listening.